Very good evening to all of you. Welcome you all for this last session of Autism SIG. As this has been the practice, we'll be having one webinar followed by three interesting case presentations. I request our President, Dr. Chapalavirti ma'am, to introduce the speaker for today, the moderator for today's session, and the expert for today's session. Over to you, ma'am.
Thanks, Mahesh. I welcome you all. Today we will be having this session, which will be the challenging behaviors in children with autism spectrum disorder. And the main talk will be delivered by Kavita Kamath, a dear friend, clinical director, possibilities, Laurel Behavior Support Services. She's done MEd in special education at the University of British Columbia and MSW from Tata Institute of Social Sciences long back in 1993. And as areas of interest are in dissemination of science and policies that guide behavior analytic practice. And she's part of the Indo-Canadian Autism Network, which has been spearheaded by Vikram Dua, who was a speaker last week. Besides this, we will be, after this, the topic exactly is importance of early intervention, understanding and addressing challenging behaviors in children with autism. And as usual, as we have experts, experienced experts from diverse backgrounds and diverse resource settings. And we are joined, very privileged to be joined by Professor Satish Chandra Girimaji, who has been a senior professor of child and adolescent psychiatry. He was retired from NIMHANS, Bangalore, and he is basically started the child-adolescent psychiatry long back. So he has been the pioneer in this area. And his areas of interest are genetics and clinical aspects of neurodevelopment disorders and child and adolescent psychiatry. And he has number of publications, and he has been on the WHO committee for the revision of ICD-11 on intellectual developmental disorders, which is really great. And he was former Dean Behavioral Sciences, NIMHANS, Bangalore. In addition, we have Dr. Faisal Zafar, Assistant Professor of Pediatric Neurology from Children's Hospital and Institute of Child Health, Multan in Pakistan. And he has done his FCPS in pediatric neurology, and his area of interest are neurodevelopmental disorders and neuromuscular disorders. And he's got many national and international publications. Welcome, Dr. Faisal. Then we have Dr. Satyamama Ramachandran, who is Consultant Development Pediatrician, Pediatric Department at Penang Children's Hospital, Penang. And we are so grateful. It's quite late in the night for you. Thank you so much for joining from Malaysia. She has done a clinical fellowship in pediatric neurodisability from the UK and has innumerable awards which she has got over last many years for her work in pediatric neurosciences. And she's member and secretary of Penang Pediatric Society and life member of the Malaysian Society of Neurosciences. Welcome, Dr. Satyabhama. We also have Professor Sevkan Karekov, a child psychiatry, consultant child psychiatry from Togus University Psychology Department, Istanbul, Turkey, with an area of interest in neurodevelopment disorders, adolescent psychiatry, and CBT. She has innumerable publications and is a co-author of the book Beyond the Diagnosis, Asperger and Autism. Seems very interesting. Would love to read it. And she's got many, many awards, including the Donald Cohen and Helmut Resmith and ECNP Fellowship, and has done a lot of projects and is the project coordinator of the Nationwide Epidemiology on Mental Health Problems Survey Project. Thank you so much for joining from Istanbul. And we will be having the moderator of the session today is Dr. Alpna Kondekar, who is a pediatric neurology consultant and associate professor, Department of Pediatrics in TN Medical College and BYL Nair Hospital, Mumbai. And she's done her fellowship in pediatric neurology and epilepsy, has many publications in national and international journals, and she's chief coordinator and consultant of multidisciplinary pediatric neuro rehab services and early intervention, and has lots of other credentials to her credit. Over to you, Dr. Alpna. And as the protocol has been, we will have Kavita deliver her talk, then the experts giving their comments from sides, and some Q&A being taken up, and then 3 cases being presented, 1 from Turkey and 2 from India. They all will be brief 8-minute presentation with 2-minute discussion so that we wind up in 90 minutes. Thank you. Alpna, it's all yours.
Yeah, Thank you very much, Dr. Shefali. I welcome all the speakers, and I request Kavita Madam to begin with her presentation. Welcome, Kavita Madam.
Thank you. I am going to just share my screen.
Yep.
Are you able to see it?
Yes, yes.
Okay, perfect. So thank you so much. I'm absolutely honored and humbled to be part of this session, and thank you so much for the invitation. I know there's such a wide range of experience and breadth of knowledge coming from different countries in this area. So I'm hoping to contribute a small portion from the field of behavior sciences to this discussion. So the topic today is importance of early intervention in addressing challenging behaviors in children with autism. And I just, during the span of this session, what I want to do is to touch upon a few key concepts that have that contribute to the importance of early intervention and so I'm going to walk us through problem behavior 101, how do children learn, understanding these problem behaviors, and what role behavior analysts or special educators can make in conjunction with physicians and medical professionals. So that's my hope, and we'll summarize some key takeaways at the end. So this is not new for any of you who are in pediatric neurology. I think this is something that we carry within all our therapies as well, that early intervention is well established in research, that it's the way, it's the best approach. And so we talk about brain plasticity, so that kids are more adaptable in the early years. The early intervention tends to yield positive outcomes. Effective early intervention can also change a child's developmental trajectory and result in better outcomes for family and for the child. Parent education to support early intervention strategies at home results in healthy parent-child interaction, which also creates more opportunities for skill building. So the energy is directed towards skill building rather than managing problem behaviors, right? And intervention is less expensive in early years. It's as they get older, it becomes more and more difficult. And problem behaviors only strengthen over time and become difficult to change. And oftentimes, the broader outcome of all of this is a poor quality of life for the individual and the family. And just to, and I'm saying this, and I want to pause here for a moment to give you a little bit more about the work that I do. I work in British Columbia, and we provide support to more than 600 children and youth and adults across different regions in the province. And in my role as a clinical director, I provide clinical supervision and clinical guidance to a team of more than 35 clinicians that are on working with me. And all our referrals come to us with crisis level behaviors. So there are children, youth, and adults, sometimes significant behaviors that are impacting families, impacting their ability to be in schools, impacting ability to be out in the community. So we work with them. That's the work we do. So we have seen the benefits of early intervention. When we work with people who have gone through early intervention, we see that the trajectory is very different compared to those who have not had any early intervention. So I want to extend, as a result of that, I want to extend and make the concept of early intervention a bit broader. So when you talk about early intervention, sometimes people talk about children, young children, children under the age of 6. Or early intervention is often associated with young children. And what I want to kind of extend that early intervention aspect is intervene early when you see a child engaging in problem behavior. It doesn't matter if they're 10, it doesn't matter if they're 12 or 14. It's something to really pay attention to rather than say, oh, it may settle with age. So here are some examples of problem behaviors that we tend to see in our practice. We see disruptive behaviors, resisting transition, could look in the form of flopping, crying, throwing, using inappropriate language towards people around in the family. Physical aggression towards others is very problematic oftentimes. property destruction, self-injurious behaviors, inappropriate sexual behaviors, and various combinations of these behaviors as well. It's not that one child is exhibiting only one of this category. And we see some behavior patterns within the population we support. Sometimes it's a single behavior, and it's a very clear form. It's hitting, throwing, biting, pinching. It's just one instance of it. And sometimes it's a cluster. So you see the parents will describe a behavior as, oh, he engages in tantrum behavior. It's very disruptive. And when you ask them to describe the behavior, you'll realize there are multiple behaviors that are forming a cluster. And in behavior analysis, we call it response class. So all these behaviors together are serving one purpose. It doesn't happen in isolation. And then you see a behavior chain, which is oftentimes escalating behavior chain. So you see there are clear precursors. You can see that the child is getting upset. And then when those behaviors are not paid attention to, or it doesn't result in what the child is wanting, you start seeing an escalation pattern. For example, starts fidgeting, then screaming, and then if he doesn't get what he wants, starts throwing items. And eventually the behavior stops when the purpose has been met, or the emotional arousal is so high that we have to isolate and try to de-escalate before anything is done next. So these are common that we see. These are the three areas that we work with families, school districts, and community partners. And we see a huge impact of these problem behaviors, regardless of the age. It interferes with learning and teaching. It's got impact. It impacts relationships with siblings and others, may cause harm, and also result in isolation for the child, with peers or within communities. And in school settings, I've often seen that they're excluded from activities because of their behaviors, and by peers, and sometimes because teachers say, oh, it's very dangerous, or parents have complained that he does this, and so there's some subtle exclusion starts happening in school settings as well. And the impact on family is very profound. And there's a lot of research supporting this. The parents experience high level of stress. It impacts family dynamics. There's a high divorce rate. There's high marital conflict. There's a drain on resources, and families become increasingly isolated and in going into community settings or reaching out to other extended family members. And there are lots of cultural factors, as I know we have lots of people from different cultures here. As you could attest, there are lots of cultural factors also that play a role in families starting to get isolated within this area of disability. Now, when we work with children, we know that there are lots of factors that already predispose learners with ASD to engage in problem behaviors, and this is not necessarily. You don't see this with every child, but this is a range of factors that impact. So let's go through that. They have limited adaptive skills. So when you see, a lot of the typical neurotypical kids, they may learn and they may observe and learn a lot of behaviors. We're not explicitly teaching them each behavior by having a teaching session. Whereas with children with autism, they're not necessarily looking and learning or observing and learning all the skills that they need to. So there are gaps in their adaptive skills. They have limited leisure and recreational skills. So when you tell a child, oh, it's free time, you're tired from school, this relax, unless you've taught them something to do during that time, the concept of relax or this is free time may be meaningless for them. So limited leisure and recreational skills are a predisposition for problem behaviors. Poor or limited social skills, so ability to come and connect with peers. They may be motivation, but they don't know how to initiate. Poor communication skills and sometimes behavioral histories of how they have experienced an environment, experienced a particular setting could also be a trigger for them for problem behaviors. And there's often lack of choice and control in different environments, because when a child has got a disability, there are a lot of people around the child who are making decisions for the child. And so that could also play a part in problem behaviors. We also see a lot of common myths about problem behaviors. And I think I do present in various forums within Canada and to parents and to professionals as well. And we see this very often, like there's delay in reaching out to the doctor for diagnosis as well in many settings. And common myths about problem behaviors are, that's just who the child is. That's just his personality, let him be or let her be. The child is just being naughty, and problem behaviors will go with age and time. That's, sometimes families have this has resulted in children being diagnosed at the age of 7 and 8 versus earlier. And, sometimes the child or family environment has caused the problem behaviors. It's not, they don't look at it as something that can be addressed. It's just that the family environment is so bad. That's why, what can you expect? And the problem behaviors are part of a child's diagnosis is a very common comment that we notice among children, parents, and even teachers as well, and that it's genetic. So while some of the factors, there may be some medical or genetic factors that is, increasing the risk of a child having autism, they are not the trigger for problem behaviors. They're not the cause of the problem behavior. So many times, problem behaviors are often learned and they're not inherent. And problem behaviors tend to serve a purpose or communicate a message. And I'm going to walk you through what we do as behavior analysts in this field to understand that. And problem behaviors seem maladaptive, but from a child's perspective, oftentimes it's very adaptive. So let's look at an example where we look at behavior as a form of communication. So imagine Sunny is nonverbal and he wants to watch TV. He's watching TV. So Sunny screams every time his mother asks him to turn off the TV. So the mother is coming saying, turn off the TV. When he screams, his mother tries to talk to him, but he escalates to hitting. He starts hitting his mom. Then his mother steps away and allows him to watch more TV. So, okay, fine. You can watch more TV. So if this pattern continues repeatedly in the home environment, Sunny has learned that screaming and hitting is an effective way to communicate that he wants to continue watching TV. So this is an example of how quickly a behavior that a child engages in can become a form of communication. And this is not new to children. When a child is born, the one behavior a child uses is crying. Crying is used as a behavior for a parent to come attend to the child right away and look at all the possible reasons the child could be crying. Do you want milk? Maybe the child needs a diaper change, or maybe the child is feeling colicky. So, and as soon as that is filled in, the crying stops. So it is very common for children to, as they get older and they have access to other behaviors, to start looking at ways to communicate with their environment to get their needs met. So if a problem behavior starts to become efficient, that is, works in no time, effective, that is, always works, and is relevant, gives the child what he or she wants, then it becomes a good communication tool for the child to communicate his needs and wants. And that is something that is really important for parents and educators to keep in mind, because we want to watch what the child is starting to use to communicate, and how parents and teachers are responding to that communication. And this is one of the reasons when we look at, there's a saying, when you see a child with autism, you see one child with autism. That's because everybody's profile is so different. And no two children with autism engage in the same behaviors. So you have to ask yourself, why is that the case? Why is the behavior profile of each child so different and so unique, although they may have the same diagnosis and they may be on the same part in the spectrum in terms of either profoundly challenged, cognitively challenged, and nonverbal, but you still see the behavior profile like very variable. It's because of the child's learning history, in addition to their diagnostic profile. So the child's learning history is key to the way they develop behaviors. And why is that the case? This is because there are two principles that are always working regardless of whether we like it or not, and it's regardless of the child with disability or without disability, adults, youth, and children. These two principles are always working on us and how we interact with the environment. So if a behavior results in something we like, or something that feels good, or gets rid of things we don't like, we tend to do it more often. That's just something all of us do. And so if something's reinforcing, we do it more. On the other hand, if a behavior results in something we don't like, or something that feels bad, or results in losing something we like, we tend not to do it. So anything that has a punishing impact on us, we tend to avoid those behaviors. We don't do it. Anything that's reinforcing, we tend to do it more. And this is across the board for all human beings. So this is well-established behavior principles that are operating on us. And I want to extend this to all the children we support. If a behavior works for a child and it's efficient, effective, and relevant, they will continue to do those behaviors. If the behavior does not work, then that's when they will stop using those behaviors. So that's why the role of behavior analysis and understanding behaviors becomes so critical at early stages. So we can change the trajectory into ways that are meaningful for the child and for the family. So when we talk about behaviors influenced by environment, we're essentially talking about what comes before, what comes and after the behavior. And so what comes before is often the setting event, and I'm going to talk a little bit about it. And it's the antecedent, and then the behavior, and the consequence is the response, which anybody in the environment, whatever is happening in the environment, happens right after the behavior. Even simple things like, think about even today, Dr. Shefali said, Kavita, you can start. That was the antecedent. I started my presentation, and the consequence is that people are able to be quiet and listen to the presentation. Simple things like a preschool teacher who walks into the classroom, and the class is very noisy. All the children are, jumping up and down, chatting with each other, making noise. The teacher claps her hand twice. Immediately, the children look at her. There's a behavior, and the consequence is the teacher says, it's time to start our session, and everybody settles down. That's the consequence. So it's not necessarily, we don't talk about ABC in the context of only problem behaviors. The ABC is also considered in research as a learning unit. A lot of the behaviors follow this consequence of A, B, and C. If you start analyzing how you go about your day, you will look at all of your behaviors have got an A, B, and C. There's even for toileting, that's internal behaviors. You feel there's a pressure in the bladder, that's the antecedent. The behavior is using the washroom, and the consequence is feeling relief. So you can extend this to various behaviors we do throughout the day. So when we talk about problem behaviors, we talk about the ABC and the setting event. So let's look at what is a setting event. Now, these setting events is not the trigger, immediate trigger, but these are factors that really contribute or increase the likelihood of a problem behavior. And from a physiological side, and it could be a child is very tired, hungry, thirsty, pain, or they're experiencing a lot of heat or cold, or effects of medication. So, for example, on a regular day, the child comes and the teacher says, or the parent says, come for dinner, and the child comes walking to the dining table and sits for dinner. But on a day when he's very, very tired and he doesn't want to get up, he may whine or cry in order to come to the table, because there's an impact of a physiological impact that's happening on the child on that day. Ecological could be the time of the day or just the noise level. Some children that we support are extremely sensitive to some of these factors. And when put in that environment, you are likely to see more problem behaviors than in a quiet environment. So crowding or crowded areas, opportunities for choice, predictability. So for example, working with children, sometimes some children love predictability. They want to know what's happening today, who's coming, what's class is next. And there are some children where there's a lot of anxiety built in, even when there's predictability. For example, working with one of the children, if they know that there's a doctor's appointment coming up, or they have to go to a dentist, and it's on their calendar, then they will be asking multiple times, when is that? When is that coming? When is that coming? Because there's a level of anxiety building up in order as the day is approaching. So predictability would have to be how much predictable you need to be for each child will be based on a child's profile. And then activity patterns. Some activities are busy and some activities are quieter. So depending on which one results in the child feeling happy and which ones are more aversive, this could be a setting event as well. Behavioral histories also play an important role. Imagine the child is used to having a particular teacher in a classroom, and then a new teacher walks in because the teacher was sick. Now a new teacher is giving instructions and they have no rapport with that teacher. That sets the stage for, it could set the stage for problem behaviors on that day because they just don't have a connection with that teacher. Could be aversive history with specific places, items, people, going to a dentist, going to a doctor, experiences that they've had in the past could really impact how they prepare themselves or how they respond to those environments when they go next or are likely to go there. So let's look at some common responses to problem behaviors, because there's agreement that's common behavior. Problem behaviors occur with a lot of children experience it. So what do we do when we see those problem behaviors? So child engages in the problem behaviors. That's the child behavior. Parent and teacher reaction, there's so many different ways we react, right? We sometimes will talk to the child, don't do this, I don't like this, whatever the explanation is, or even maybe a reprimand to the child, scold the child. Another response could be just comforting the child, especially when the child engages in self-injurious behaviors. We see this very often, where the parent will say, don't do this, you're hurting yourself, and holding the hand and hugging the child and saying, don't hit yourself. It could be taking away items or the demand by saying, oh, you can't watch TV anymore, or taking away items that they are playing with to say, stop playing with this. That's it, you're behaving like this, I'm going to take this away. It could be move the child away, that you can't play here, I'm going to make you sit in the corner there. Or stop the activity. Give the child what he or she wants. The parent could just say, okay, fine, you can have it. So there are different ways parents respond. Sometimes step away from the child, sometimes introduce something they don't like by saying, no, you have to do this now because you behave this way, now you're going to do this. So, and at times, these reactions are also inconsistent based on the parent's mood, based on how busy they were that day, based on what other siblings are doing in the house. So there could be some variability in how they respond. But all the time, the pursuit of the parent and the teacher is to arrive at an outcome where the behavior stops. They just want to stop the behavior, right? Whatever stops the behavior, bring some calm, and so that they can carry on with their activity. So you could ask the question, why is this a problem? If this is achieved, why is it a problem? Why can't they pick any of these options as parent responses and just go on their day if it really essentially results in the behavior stopping? There is a problem. And that's why it's important to pay attention to how we're responding. So some strategies are perceived as punishment by the parent or the educator, but they may actually strengthen the problem behavior if we don't understand how behavior is working here. And these strategies will temporarily stop the behavior, but have significant negative effects. And long-term consequences can be quite detrimental for children. So let's go through some examples. How does a teacher reaction strengthen problem behavior? So let's look at an example. John hates math, and when he was frustrated, he threw his book and yelled at the teacher. The teacher sent him to the principal's office. John was very happy to be out of the class, chatting with people who visited the principal's office. So you can see here, the teacher thought, I am punishing him. I'm going to send him out of the class. So if this pattern continues, John learns that when it's time for math, which he doesn't like, he throws the book, he can get out of it. So he's learned a tactic to escape a math class. And the teacher also learns that when John throws and yells, the best way to bring calm to the class is to send him out of the class to the principal's office. So both are realizing that the child is realizing that I've found a way to communicate that I want to escape math. And the teacher is learning in order to bring calm, I need to send him out. But it's not really serving any purpose for both. Like it's not teaching the child how to be in a classroom and learn math, and neither is it teaching the child how to include a child with diversity in a classroom. How does a parent reaction strengthen problem behavior? So mother asks Raj to put away his books and clean the table. Raj knows how to clean the table and put away his books, but he does not respond after repeated requests. Finally, his mother gets upset, raises a voice, and says, "You never listen. Go to your room." Raj goes to his room and plays with his iPad while mother cleans up. These may seem like simple examples, but you can replace the behaviors and look at how problem behavior can start building up to higher levels of escalation when they get older. Raj learns that in order to get out of cleaning, he just needs to ignore his mother's request long enough for the mother to get frustrated and say, "Okay, I'm tired of talking to you. Go to your room. You don't listen." So mother learns that in order to get the table clean, she just needs to send Raj to the room and do it herself. So over a period of time, she starts doing it rather than teaching Raj to do some of those life skills that are important. There are some negative effects of punishment as well. It really teaches what not to do, but not what to do. So telling a child, stop doing this, don't do this, go to your room, oftentimes, child does not learn how to respond to those situations appropriately. So there's an opportunity for skill building that's lost. Problem behaviors will likely continue in other contexts because the child has not developed any skills. It stops the behavior and it gives an illusion that it's an effective strategy. So when the parent experiences the calm or the teacher experiences the calm, they may think this is a great strategy. It's working really well, right? So it may tend to keep going that way, but there's an opportunity that's lost in teaching the child. There are some negative effects of punishment that's also well documented research. Emotional or aggressive reaction. The child may become aggressive towards self or others, or may direct the aggression towards the parent or educator. So if the response is, "I'm going to take away your thing. When you do this, I'm going to just take this away, or I'm not going to let you do this, or go sit in the corner," there may be escalation of behavior resulting in aggression. It could result in escape avoidance. So child may lie, cheat, or hide, or engage in other undesirable behaviors to avoid the escape or avoid or escape punishment. And you see this even in typical children. If there's one parent who's more strict than the other, then they tend to behave differently in front of that parent versus in front of the other parent. They tend to share less information with that parent compared to the other parent. So when there's a punishing influence by a parent, there tends to be behavior changes that the child engages in. There's also undesirable modeling. So the child may copy or imitate the parent. So if they are yelling, the child may also learn to yell. If they are doing other behaviors that indicate escalation, they are likely to engage in those behaviors as well. And another side effect of another result or impact of punishing strategies it results in contrast. So the child engages in appropriate behaviors only when the punisher is present. So only when the person who tends to be to punish, they behave differently. And when they're absent, problem behaviors tend to be at a higher rate. Another reason we talk about early intervention and why it's so key, it's also for parents. Because parents, children go to school, they may be there for 6 hours, 5 hours, they go to therapy session for a few hours here and there, but parents are there all the time for the child. It's very important that we pay attention to what parent-child interaction looks like in the early stages. And there's a lot of research that's been done by Dr. Patterson, Gerald Patterson, and he talks about the parent-child interaction. And it's the coercive cycle that's built over repeated interaction in certain ways. So it's a pattern of interaction between a parent and child that often results in worsening behaviors in children or a loss of control in parents. So unless the parent understands how they are contributing to the problem behaviors, it would be very difficult for them to break the cycle and move towards a more positive and a more productive interaction with their children. So let's look at some examples. So this is called a parent-driven, sorry, I can't see, there we go. This is a parent-driven interaction. So parent says time to do homework, turns off the iPad, and it's directed towards the child. The child ignores the parent, refuses to do it. Parent increases the escalation, turn off the iPad. So there is a higher level of volume. There's an emotional arousal there by the parent. That results in the child also having an emotional arousal. No, I'm not done, by screaming. The child continues to argue. Parent backs off, gives up, and then the child keeps playing. So you can see that this dyad of parent-child interaction, and if this keeps going on, much like the examples I shared before, this creates a pattern of interaction between parent and child. Neither the parent or the child, this is not a productive engagement. And it could, think about a child who's 5 years old doing this, but think about also a 15-year-old autistic child engaging in a coercive cycle. That it could be scream, it may escalate from screaming to other behaviors that could be quite dangerous if those kind of patterns continue. Now, this is a child-driven coercive cycle. The child is asking the mom for chocolates. He makes a demand. Parent says no. Child increases the volume and screams, I want chocolate, throws a fit, maybe flops on the ground. Parent looks at the child and says, mom, gives him some chocolate. So gives in, and the child immediately quiets down, stops screaming, and the parent escapes the screaming and experiencing the calm. And you see this often. There's a very common pattern, particularly either in grocery stores or in the community, where the parent immediately becomes conscious of how their child with autism is responding in a public space, and right away wants to establish some sort of calmness or ability to carry on with their routines. Now, this is what happens if this, we're looking at ongoing patterns of interaction in the family home, which is very common when we talk to families that we work with. We see that some of the behaviors have a history of 5 or 6 years, that this is always how they have done it. This is always how they've responded. So I always explain to parents, it's like adding concrete slabs on one thing. It's really hard to change because the child has practiced it for 7, 8 years, those patterns. And that's a very hard coercive cycle that's been established in the family environment. To break that cycle starts becoming more and more difficult when the kid gets older. So in this coercive cycle, typically problem behavior occurs, parent reacts, their behavior stops and there's some calm. And that's all. Like, we're just waiting for the next time to the behavior to occur and the cycle continues. But what we also know from research is that there are strategies that we can do to break the cycle. We can understand, assess behaviors, and look at how can we change the cycle to make it more productive. When the children are younger, it's a lot easier to do. So when you say the same cycle, time to do homework, turn off the iPad. The child ignores the parent. Parent removes the iPad and says, first homework and then iPad. And stops talking, removes the reinforcement. The child is left to do homework, and then The parent has an opportunity to praise the child. Nice job doing your homework, gives positive reinforcement. Child gets access to the iPad. So the context is still the same, but the behavior pattern and the interaction between the child and the parent has been changed to a more positive interaction, where there is some skill building happening and there's less of an emotional arousal and negative interaction between a parent and child. Same with a child-directed cycle. Child begs for cookies, makes demand, parent says no, child escalates to whining, parent says no, and does not give in to that. The child immediately realizes their behaviors are not resulting in a good as not being a communication tool. The parent is not listening. Child calms down, stops arguing, and the parent moves from the cookie aisle. The child realizes they're not getting it, and the child makes a counteroffer. So some children are very good at negotiating. Can I have it after? They will say things like, can I have it after? And the parent then says, yes, you can, stays engaged, and the parent then provides the cookie after they finish the shopping. So once the parent understands their contribution to this coercive cycle, we are able to break that cycle. So what is the role of behavior analysis? And we talked a lot about behaviors. So we focus on addressing behaviors that fall under the 3 categories, which is the categories of autism diagnosis as well: language and communication, social behaviors, and repetitive behaviors. And we really look at, we don't focus on what the child is doing alone. We look at what the child is doing and then try to understand why is the child doing it. So our focus on all behavior plans is to understand the communicative intent behind problem behaviors. What is the child trying to get at? What is the child trying to achieve? And that we call as the function. So shifting our focus from what to why. We use various methods of assessment, like, it's called functional behavior assessment. We look at conducting interviews with all the significant people in their life. And some of the interview questions include, when is it likely to happen? How does the child express when he doesn't like things? How does the child ask for things? So trying to understand the child's communicative repertoire. Also trying to see, are there any particular contexts that are more difficult, specific routines that are more challenging? And are there times when he's very successful, when you see 0 problem behaviors? What do those contexts look like? So we try to understand what are some factors that may be contributing to the problem behavior, and why is the child trying to use problem behavior? What are they getting out of it? That's the purpose of a functional behavior assessment. And there's decades of research showing the efficacy of these methods. We look at indirect methods, that's the interview and Likert scales. We also look at direct methods, which is direct observation. So oftentimes we would be in family homes. If it's early morning routine, that's challenging. We would go to family homes if it's late night or in the afternoon in the community, trying to understand the interaction between the parent and the child, seeing what are some factors that are triggering the behavior, what does the behavior look like, and how are people in his environment responding to those behaviors, to understand what the child is trying to communicate. And we also do functional behavior observation and analysis. And this is the analysis aspect of it is more experimental. In other words, we try to, in some contexts, when the behavior is not dangerous, we will try to provoke it. And by saying, if the parent says he always does it when this happens, we'll say, let's see if we can turn on the behavior and turn it off. If I turn off the TV, you think he's going to scream? If that's the anti-trigger, if I turn off the behavior, he screams. If I turn on the TV, will he stop the screaming? And it's simple things like that we can actually try out and show the parents that, look, it's the A and the C that's resulting in that behavior, right? It's the how the trigger is being presented and how people are responding that's resulting in the child using that behavior to communicate his needs. So the two broad functions that we look at from behavior analysis point of view is that, is the child trying to get something? So are they communicating, I want something? Or are they communicating, I don't want or don't like something? This could be an item, this could be an activity, this could be an attention of a person. And I don't want or I don't like something could be, again, a place, activity, or a person they don't like. Right? So they are working towards adding something as part of the consequence when they want something, or getting rid of something when they don't like something. There's another function that that we also look at, which is kind of automatic function, where it's not mediated by the environment. So we don't really see the A, we don't really see the C, but we know that the child is engaging in behaviors, and many of you may have seen it with children that you work with, particularly those with autism. You see repetitive behaviors, and sometimes they're engaging in repetitive behaviors in complete isolation. They're doing it, nobody's around, nobody's responding to them, but they're doing these things. And some of these behaviors may have a sensory component to it. So we call it automatic reinforcement. In other words, they are finding some sort of a satisfaction internally. So either to get rid of something or to get out of something or get something, but it's internal and we can't really quite tell. And I get a lot of questions about this, and I often, when I'm presenting, I ask people to reflect on all the behaviors we do in isolation that are repetitive, where we get some satisfaction. So there are behaviors we do that sometimes you can't, it's not socially mediated. There is no antecedent, there is no immediate consequence in the environment. Things like we stare at the ocean for hours. We binge watch Netflix. Why are we doing those behaviors? Because there's an internal satisfaction that we experience. We pace up and down, we go for long walks. That could be because we enjoy the nature, but it could also be we are very anxious about an upcoming event and we want to kind of help cope with that anxiety. So this is something that's internal. And we do see this with children with autism as well as a function. And what do we do with that information when we look at the function? We look at establishing the central pathway. We explain to the parents, this is what's currently happening. When this trigger is presented, your child does this, and this is how you're all responding in the environment. So there's a function, there's a purpose. And we also identify the setting events that's likely, increases the likelihood of the problem behavior. And we explain that the central pathway will continue as long as the child believes this problem behavior in blue is meeting their needs. So if the child is engaging in a behavior and it gets them what they want as a consequence, they will continue to be engaged in the behavior. And as behavior therapists and special educators, what our job is to change the route to an alternative behavior so that they can get what they want, but in a more appropriate way, and eventually move towards the desired behavior that's on the top, which is the long-term goal, and where they build more skills. So I'll look at one example that I shared in a recent session. So here's the example. This is a child with autism who is 8 years old. He's minimally verbal, attends school during the day. I can't quite, and has limited play and leisure skills. He's the only child and lives with his parents who have a busy family and work schedule. So here, a setting event, he's had less sleep. So when he has less sleep, he is more likely to want his mother's attention. And during that time, when the mother goes to the kitchen and he's busy cooking, he tends to scream and pull at mother's clothes. And when he does that, the mother comes and sits with the child. So he has learned that this is the best way to get his mother's attention. So as from a behavior plan perspective, what we would do as an assessment, if this pattern is established, we understand the mother's attention is the function of the behavior, and we teach the child a better way of getting the mother's attention, which could be teaching him to use a visual or teaching him to use words, pressing a button, that voice output button, so that instead of screaming and pulling, he can, as a short-term goal, learn how to access mother's attention in an appropriate way. And then the long-term goal, which is at the top, desired behavior, would be to teach him some recreational skills and leisure skills so he can engage independently when the parent is doing another activity. So he's not always having to cling to mother's clothes or screaming the moment the mother steps away from the child, which is an important life skill to have as the child is growing up. Otherwise, it becomes extremely difficult and stressful for the parent to be beside the child at all times. So this is typically the outcome of a plan. And our treatment plans include, it's a function-based plan. It would include preventive strategies. So what can the parent do before the problem behavior occurs? So a lot of simple things that we teach the parents to do, and you know, we work with the parents to say, does it match your routine? Is this something you can do? So it's contextually appropriate and clinically sound. We teach strategies like alternative behavior and desired behavior. And then we also coach the parents on how to respond to the child differently. So for example, if they continue to respond to problem behaviors, say for example, going back, if they continue to respond to the problem behaviors, then the child is going to think this pathway continues to be efficient. So if you want to change this pathway, we've got to change how the parent responds and ask the parent to respond differently to problem behavior versus alternative behavior. So that's part of a treatment plan. And the medications prescribed by a doctor is one component of the comprehensive plan. So we always make sure that that's always included, because medical assessment is always happening concurrent with behavioral assessments when we're working with children. So behavior analysis is data-driven. So we measure baseline, how often, how long, how intense the problem behavior is at the start. We look at treatment. So we develop the plan. We establish strategies to decrease problem behavior, increase adaptive skills. And then we measure behavior to see whether our treatment plan has had an impact on the challenging behaviors. So behavior analysis is a science, and it does follow the scientific approach of looking at data to drive those decisions. And we measure all the way through, and there are reasons why we coach our team on why it's important to measure. It tells us how often, how long the behavior occurs. It tells us if our intervention or the medication is actually working. A medication, but that's oftentimes, we also include medication because we have doctors involved in the support of our child, and they introduce medications. We want to make sure we are collecting data for that as well. It prompts us to make changes to the plan and medication if necessary in a timely manner, so we can go to the doctor and we tell the doctor that these are the observations of behaviors we are seeing when medication was introduced.
I think there's some issue with
some issue. I think Kavita, we lost your voice. Must be some network related issue.
Okay. Meanwhile, as she joins, Dr. Girimaji, you would like to add something as an expert. Please, till she joins, and when she joins, then we can let her continue. Sir. Sir, you are mute.
Sir, you are on mute.
Very nice presentation. I really liked it. Very down to earth, very practical, and she has given a very understandable functional behavioral perspective on the origins, maintenance, as well as the behavioral therapeutic management. And what I particularly liked about the presentation is the emphasis
So
on
she's back. Sir,
Yeah.
sir, Dr. Kavita, yeah, please you can share. I just told sir to
Kavita,
ask, yeah, Hishaya, please, yeah, yeah. Sir, thank you. Thank you, Dr. Girimaji. After Kavita finishes there. Kavita, you're on mute.
Oh, sorry. I'm so sorry. I don't know what happened. I just got kicked out. I think connection. Anyway, pharmacology and behavior support. Well, what we know is that medications are not effective if the behavior is a learned behavior. Medication is not a solution to it. And behavior strategies are not effective when there are underlying medical issues. So, it is something that we have to understand from early stages that I know it's very easy for parents look at it as a diagnosis, and when in the medical realm, when there's a diagnosis, there's a medical treatment. And so even here, we work with a lot of very culturally diverse families, and they're like, can I just get a medicine for this? Can I just get something that's easy to do? And behavioral strategies take a lot of effort. And so, if there's a better way and a shorter way to eat a pill and get a solution, then obviously that would be great, but there isn't. This is where we have to work together with both the medical team. There's a therapist. I'm not just saying behavioral therapist. There's occupational therapists. There's speech and language. There's physiotherapists. So there's a whole host of therapies that really could benefit from an early interventions perspective for children. So really important to keep this in mind. And so the treatment design needs to be an interdisciplinary approach. And the purpose is, what symptoms are part of a biological, physiological condition that could be addressed with medicines, and what behaviors are learned that can be addressed using a behavioral approach. So and unless the parents understand that there are these two different areas, not everything can be covered with medicine. It's going to be really difficult to get them on board to also understand their role in the treatment process. So, I presented this recently, and I think it resonated with a lot of people, and I thought it would be helpful to talk about it here as well. So what does research on the use of medication show? There's a very high reliance on medications to address challenging behaviors in children and adults with autism and IDD. I do see it. We work with a lot of youth. We work with a lot of adults, and they have so many medicines on their MAR sheet that, and we ask a lot of questions about what is this medicine for? What is that medicine for? And there's a host of reasons that these medicines are there for, and some of them do have mental health conditions and other psychiatric diagnoses. We do see a lot of comorbidity, particularly as they get older. And so understandably, they need some of that for sure. But psychotropic medication use in the population is often prescribed off-label and not for the purposes approved by FDA. And there's some research supporting that as well. And there's multiple medications are prescribed for optimal effect. And it's hard to determine the efficacy of a single medication when multiple medications are prescribed. So how are we understanding which medications actually having the effect? Like, it's really like, so, sometimes we look at, you can do homeopathy, you can do biomedicine, and you can do cultural practices, but then, and if you see better outcomes, who do you credit it to, right? You're really trying to figure out what is the reason for this behavior change or the impact. So there are a lot of research gaps here, and I know so many of you are involved in research, so this may be of interest to you, that despite the widespread use of medication, there's limited research on impact of multiple psychotropic medications on challenging behaviors and the adverse side effects. So the research on adverse side effects is also limited. And also, one of the areas that's of real interest to me is that how it impacts child's current behavioral repertoire. So if medications are changing current behaviors that they already have, what does that tell us? So if they are able to do something, and as a result, as a side effect of a medication, they're not able to do it, like what are some consequences of that? So decisions, just furthering the conversations about that collaboration piece, and decisions on medications and dosage changes are often based on anecdotal information. I have sat in many of these meetings with doctors and parents, and oftentimes when we are new to the case, we join these meetings just to understand the profile of the child, trying to understand what role we can play. And we noticed that there's a lot of anecdotal information from parents, teachers, and care providers provided to doctors during these visits. There are indirect measures, including rating scale, like, how is he doing? What did last week look like? Is he doing better? Like this, and the parents will share stories and experiences of what that look like. That is a concern, like to all of us. I always joke about it. Like if I ask you 5 days ago, what did you eat for breakfast? You won't be able to remember. So when doctors' visits are spaced out into once in 2 months or once in 3 months, and a parent is being asked to recall so much of information about their child, they may not be accurate or they may not be substantial. It may highlight recent events that are fresh in their memory and shadow the success, that overall trend, right? So if an incident happened 2 days ago and you're meeting with the doctor, you're more likely to discuss that incident in fullness and forget that 28 days he was very successful. Like, really the highlight becomes this one incident that was a critical incident. It's also difficult to gather information for nonverbal and minimally verbal children with intellectual disability. And so you're really basing it on the parent bias. The parent thought it was important, they'll report it. Parent didn't think it was important, they won't report it. If it impacted them, it's reported. If it didn't impact them, it's not reported. So oftentimes you see rater or bias over there. It's also ineffective, time-consuming, and unreliable. So there's a lot of, and you take a look at any other medical assessment, we don't rely so much on just recall information, just for a medical assessment. But in the field of disability, oftentimes that is a default. And here in Canada as well, it is that, right? That's oftentimes parents don't know how to report information more accurately. And also the adverse side effects may impact behavior or result in a new behavior. So that's a really interesting thing that I have been reading a little bit more on. So, and they also change the function of the current behavior. So there could be significant impacts of these psychotropic medications. So let's look at an example, and this resonates with some of the individuals we are currently supporting, and we're working with some medical professionals on this. So on the left-hand side column, we're looking at intended effect of medication is to decrease the target behavior. So they're giving some medication because they're engaging in maybe compulsive behavior, there's impulse control, there may be an element of psychosis. So they are engaging in some behaviors that the medication is being prescribed for. And we are seeing that there's a decrease in that behavior. That behavior is decreased, right? But then you see an adverse side effect. You see dry mouth. And as a result of the adverse side effect, we are looking at a new problem behavior that's liquid-seeking behavior that escalates to aggression when we attempt to block it. So one youth that we were working with, he was starting to drink water from a toilet. That's how significant the adverse side effect was, that he was constantly seeking water. And he was nonverbal, and the moment you try to block him from water, there was aggression. So you can see that there's a new behavior surfacing, whereas the medication was effective for the target behavior, but there was some adverse side effects. Same thing, increase in appetite, eating anything available, including raw food. We have worked with individuals where we had to lock the fridge because they were even targeting raw meat, despite food being available, other food being available. Dull and depressive-like symptoms. So if the medicine worked for one, but we're seeing adverse side effects of dull and depressive-like symptoms, and the behavior change that we see sometimes is they no longer like items that we're highly reinforcing before. So parents are telling us that he used to love doing this, but he doesn't like it anymore, right? So now things that we used to use as reinforcers are no longer effective. Or another adverse side effect could be extremely tired and lethargic. So result in demand. So that could result in demand avoidance behaviors. So wanting to escape any work that's being given by the parent or the teacher, or just clinging to parent. So there's a clinging behavior that results because there could be an adverse side effect of lethargy or fatigue. And when you see that, the possible outcome, so without a systematic assessment of adverse side effects and objective data on the impact of behaviors and any change in challenging behaviors, that can be attributed to medical, it could be attributed to medication ineffectiveness. So when we don't assess all of this, we look back. So we look back over here, and when we see these behaviors, if you're not understanding information and collecting data, we could think, oh, the medication is not working, because we see all these things, right? This often results in change in medication, change in dosage, or additional medication or other adjunct treatments being added on. So the case I'm trying to make, and I'm going to come to how we can help and how we can work in collaboration, is a systematic method is needed to inform improve medication prescriptive practices, reduce the subjectivity in assessing the impact of medication, factor in behavioral assessment, and help us study the impact of medication on other adaptive behaviors that the child is in child's repertoire. So how can we help? Like, what can we do to work in partnership with the medical professions? And what we do here is that we coach teams to collect objective data on problem behaviors to inform medical appointments. We say, don't go to the medical appointment and say, he was okay, he's somewhat better, or I'm not quite sure, and look at a husband and say, what do you think? Is he doing better now? That's very anecdotal. It's based on full recall. That could be inaccurate. So we try to coach them to say, collect objective data before you go to a medical appointment on behaviors. And when did the medication get introduced? What impact it had on sleep, mood, behavior patterns. Let's take that information to the medical appointment so decisions can be made based on that. Analyzing impact using a single subject format. So, you know, if one medication is introduced, we look at let's see the impact first before the next medication is introduced, when it's possible, of course. Being part of a doctor's visit, so we can ask, we can ask relevant questions and inform behavior treatment protocols and other therapy protocols, and gather data on the impact of medication on other behaviors and routines. So just like the chart that I showed you, just trying to understand how is it impacting. I hope that's a lot of information. I just want to kind of summarize by providing just the key takeaways. If there are some things that resonated with you, I am hoping that these would be some of the key takeaways. First thing is early intervention results in better long-term outcomes for the child across the board. No dispute about it across all fields. And early should be extended to when you see problem behaviors, not necessarily associated with age. So not necessarily young children, but early intervention is early intervention. It could be young children, it could be when you see the problem behavior first. Problem behaviors won't just go away with age and time. So address problem behaviors early. It only gets tougher as they get older. I have worked with many families where the mother is 5 foot tall and their son is 6 foot tall. And there's such high risk of aggression that the parent has in some situations has said, I can no longer look after him. Because it's very difficult when you aggressive behaviors or behaviors are not addressed. They get older, they become stronger. And what used to look like a small hit or a tug at the mother's clothes now can become significantly intense. Oops, sorry. Coercive behavior patterns can hinder skill building. So breaking the cycle will result in is important for healthy development. Problem behaviors have a purpose, a function, and it is our job. So the burden of change is not on the child because we are part of the antecedent and we are part of the consequence. So it is part of our job to figure out what the function is and teach an alternative response to help the child meet his needs and wants. A positive behavior support plan is multi-component. So it's not a single strategy. We're trying to work with the parent to look at how to prevent, how to teach, and how to respond. All three categories. Supporting a child with ASD needs an interdisciplinary approach and not a linear approach. Data-based decision-making yields better results in all therapies, including medical therapies and behavior therapy and other therapies that the child may be subjected to. I do have a couple of slides that I've included. I've included some references, and there are some useful links for anybody who's interested. I do want to highlight that all of these things are free and of no cost, and they provide detailed tutorials on autism, parent education modules, functional assessment, and on positive behavior support. So you can access those. I've also included a host of research articles on psychotropic medication and behavior management and behavior assessment, if that's of interest. And I will stop sharing and open it up for any questions.
Yeah.
I think I'm right on target.
Yeah. Thank you, Kavita. That was an amazing presentation. It was so simplified that the problem behavior now doesn't look problematic anymore. More than that, you enlighten us with the risk factors which are responsible for the behavior, as well as the component of sensory behavior behind this all problematic behavior, and even the parent-child interaction. Very beautifully, you have told us everything. So first, we will like to take some views from Girimaji sir. Sir, will you please continue whatever comments you were giving us about this? Thank you.
Yeah, very nice presentation. Like I said, very practical, very down to earth. And tips. What I like most about it was, home-based parent-mediated approach that she stressed on, how to transfer skills to parents, how to help them to understand the behaviors, and how to empower them and get them to become more and more competent in handling these problems by themselves, especially in the early stages itself. And now I have to speak like a psychiatrist, child psychiatrist. So I will do that. I agree with a lot of things that she said about medication, but they do have a place in the management. And not all challenging behaviors is a very big umbrella term, and it includes all kinds of things. And one of the things that it includes is in autism, especially psychiatric comorbidities. So we have externalizing disorders, we have internalizing disorders, and we have other kinds of disorders. They all can present like challenging behaviors. A very meticulous diagnostic workup will definitely, help you to focus on what's the diagnosis and choose the appropriate pharmacological treatment. Not all children with a diagnosis, for instance, in those who have mild ADHD, you don't require medication, in the presence of ADHD, autism. But when it is moderate or severe, child is actually responding, like she said, to a lot of internal cues, has severe problems in behavioral regulation, child needs medication. Otherwise, there is no other way. And of course, this has to be complemented by the behavioral methods of management. And when they go together, the synergistic effect of these two interventions will really show up. And of course, it's not just about prescribing medication. For instance, I may choose clonidine, I may choose methylphenidate, or I may choose atomoxetine. And the choice depends on a number of factors. And this is what is called as the management of medication or management. It's not choosing the medication. And also meticulous, evaluation of the effects of medication, adverse effects, always taking stock of the benefits and risks involved, I think will help us to maximize the benefits of medication and minimize the risks such as side effects.
Yeah.
That is one problem. The other set of disorders, which I would like to highlight, is internalizing disorders. They also can, especially in autism, a child with severe social anxiety, put him or her in a place where there are a lot of crowd, child is really show up a big meltdown and all kinds of challenge. Similarly, child with trauma and stress related problem. I've seen so many children with PTSD kind of symptoms, recent onset behavior change. You sit and really uncover the history, you get a traumatic incident, And from that point on, child has shown all kinds of desirable behaviors, especially in situations where there is reminders or triggers or flashbacks. So it's always possible to kind of uh, zero in on the diagnosis if one does a very meticulous diagnostic and thereby give the benefit of medication to the child. And of course, many a times both the approaches go hand in hand. I would say 100% of children require behavioral and psychosocial interventions, and maybe 20%, 15% of children with autism require medication. I stop here because of short.
Yeah.
Thank you, sir. Absolutely correct. Actually, that's why I requested Kavita for this talk. What happens with pediatric neurologists and psychiatrists having problems, without going into and analyzing it, one medication, another medication. So, so to avoid, to have a rational use of medications, to look at the behavior in a different way, which we usually are not trained to look at. That was my idea for this. Sorry, actually, Alpna, I came up because in between, I think, Faisal, would you like to say you had raised your hand, please?
Yeah,
Dr.
I
Faisal?
think
Yeah. Dr. Faisal?
no, he is not there.
No, he was there. No, he had just raised
Yeah,
his
he
hand.
was
It's
there.
okay
He has
if,
raised the hand.
yeah, it's okay. Then he'll come back with the signal. There's some
Yes.
rain there. So, Dr. Sefkan, can you please say a few words from your side, your experience before we'll have you, and also then we'll have Dr. Satyabama say something before we have the two cases. We have only two cases and we'll have, because we're running behind time. Sorry, that's why Alpana I pitched in because to
No problem,
expedite it. Yeah.
Okay, thank you. Also, I want to thank to the presentation of Dr. Kamat. She explained a very important topic in detail and very comprehensively. And as she emphasized, management of these behavioral problems is multidisciplinary, actually. I'm a child psychiatrist, and I agree with the Dr. Garimaji as well, because there are many comorbidities, and we have to, as medical doctors, we have to work with the educators of and parents of these kids with ASD. I think it's very important topic, and it will be more and more challenging in the future also, because the incidence of ASD is increasing, as all we know. Thank you for the presentation.
Yeah,
Thank you.
I think Dr. Fazal is there. Dr.
Yes.
Fazal,
Yes.
you have raised the hand.
Yes.
Want to comment?
Yeah.
In any case, she has to make comments.
Yeah, very nice presentation. And obviously, in our part of the country, we used to do this early intervention, and she elaborated quite all the elements. Obviously, the good early intervention service that must be individualized by to the child. It should be family centered, working towards the goal, towards achieving goals which are concerned with that particular family. Obviously, we should do the assessment before the starting, and then should proceed with the data taken, and the progress should be measured adequately. And obviously, if this early intervention is child centered and developmentally appropriate, that will be have very good effect. This is obviously we should use more positive reinforcement and takes a strength based approach. Obviously, that's how we can move the family and ask them to have regular meetings, so that we can have a good track of all the progress and have a good role in the problem solving. Obviously, that's how we can be able to the child to practice, and obviously these new skills and many settings can be at home, later on in the school, not just in the therapy settings.
Yeah, thank you. Dr. Satyabama, any comments from your side?
Hi, thank you, Ms. Kavita, for a very enlightening presentation. Very simplified, very easy to understand. I'm a developmental pediatrician, and in our developmental pediatric clinics, we tend to do this quite a bit, actually. We do functional behavior analysis. We give parents the ABC charts. We actually take a bit of time in looking at the behavior, and we look at the antecedents, exactly like the way you say it. It's just that the time taken, in our clinics, it does take a bit of time, actually a lot of time. And sometimes, the waiting time gets longer because of this. But I also agree with Professor Giri Maji that I think medications go hand in hand for some patients actually. And, but we don't usually start at the first go. We do the functional behavior analysis, but I feel that personally it works better when it goes together. Even if we do start medication, we do behavior training as well after looking at the behavior. Thank you.
Thank you.
Thank you so much for your responses. I really appreciate that, and I agree with so much what you're saying, that yes, it does go hand in hand. We see a place it's an important place both medicines and behavior therapy and all the other therapeutic approaches have. I mean, just the diagnosis of autism, you look at how the diagnosis is done, it's so behaviorally based. There's no other way we can look at the treatment if we take away that component of it. So yes, it does go absolutely hand in hand. I appreciate your comments, and I'm glad the content resonated.
Yes. Also, the other thing
Kavita,
is when we see, sorry, am I interrupting anyone? Okay.
No,
You
please
also
continue.
mentioned the other thing I like was the profiling of the child, because that's what we do. We look at the severity of the autism and then the comorbidities and also the level of functioning of this child, the adaptive functioning, the cognitive functioning, and the learning as well. So you look at it from all angles, and that actually helps us to plan, the behavior management and all that. And I quite like the fact that you emphasize on that data collection for medication. Actually, I mean, we do use rating scales, but I think we need to be reminded, to look into like this, parents will often tell you exactly the way you mentioned, yeah, they seem a bit better, or they'll ask the spouse and all that. But, maybe it's a good reminder for us to be a bit more objective on how it affects specifically the sleep, the diet, and the mood and everything else.
We have started doing it a little bit more with the older children now, because we are seeing that we go into these medical appointments, and so even the doctors have been telling us that that's very helpful for them to have that data in front of them, like to have the sleep chart, the sleep mood chart, to look at their eating patterns. Have they changed? Has there been a change in behavior patterns? So when we collect that information and go, I think that even the doctors have appreciated that they have more information to go off of rather than just an anecdotal note. So I think there is some value in that from our perspective, because we are also kind of data driven. So it helps to coach on all fronts when we're working with parents to get them ready for the medical appointment, essentially.
Absolutely. And, as you had mentioned that if you had a meltdown recently or something, the parent will remember that. But if you're noting down in the diary, so you're having it there. And another thing is it'll de-stress the parent also. If you're noting it down, you're not anxious or stressed to remember. They have too many stress on their own initially. Kavita, would you be having time to stay on for 15 more minutes? You have an assignment, because there were two cases actually got late. So we have one from Turkey, one from India. So is it okay if I extend by 15 minutes, or you have to log out? If you have to log out, then no, you can log out, because fine. Whenever you
Okay.
can just give a take-home messages, because I think mostly what is there in the chat, there are a lot of appreciative ones, other medications and all were discussed in the last sessions as well. So basically when Vikram was there, so I think you can just you can give your take-home messages, then we can start the case from Turkey. You can stay on till what you can, but then so at least you give your take-home messages from your presentation for the various professionals across who are there, so that and we'll request you if you can stay till whatever time when I'll ask Kevin to start her
I can stay for
training.
15 minutes.
Yeah, sure. But
I
then
can
whenever
stay
you
for
want
15
to
minutes and then I have to hop on.
Yeah, so the moment you want to leave, before that 3-4 minutes, you please switch on your camera and just give a take-home message that time. So that it's customary to give take-home message. You can give right now also in case you want.
Okay, I will do it right now. I feel I will do it right now. The take-home.
Okay.
I think for me, the take-home message is that everybody's wanting their needs and wants met, and children with autism, if they struggle with communication and they are wanting their needs and wants met, they are finding whatever is the best way within their environment to get those needs met. And the one thing, and they're learning through these interactions and patterns with families, they're learning how to get these needs met. So what I want to always tell parents is I want to give them always a message of hope. Look, your child has learned that by screaming, I can get mom's attention. Don't worry about the problem behavior. Focus on the fact that he can learn. He can learn. Like that's the message that I always tell the parents to say, that he can learn. Let's not get, focus. Let's not focus on the fact that he's screaming right now to get his needs met. Let's focus on the fact that he has learned that to scream to get your needs met. And let's shift that learning to better and adaptive skills. So I do hope that we continue to have a more interdisciplinary approach, and early intervention stays on our radar throughout. It doesn't matter what age it is, but early interventions is critical. So that's my message.
Yes, thank you, Kavita. And I want Professor Veena Kalra to
Thank you.
give her opinion before we open for the case. And then from Turkey, please be ready to share your screen. When Professor Kalra, your take on this, please. Professor Veena Kalra, yes.
Okay. So it was really a wonderful presentation. It was bringing out the detail about analysis of behavior, how to take it up with the parents, how to advise the parents, how to deal with the situation, and the intervention of medicine versus behavior as a composite way of management. What I need to add is that while these behaviors are there, they are so different from parent to parent. The mother faces this behavior in a very different way, and the father receives the behavior response from the child in a very different way. So I think there's also something to learn, that it's the same child, it's the same situation, it's the same family environment, but the child responds and interacts with the parents in such diverse ways. So there's a lot of learning to give to the parents as to how to modify their own behaviors toward the child, rather than only look at the child's behavior. The mother may say the child is totally unmanageable. As soon as the father comes back from the office, the child is quiet, the child is nice, the child is well behaved. So he has learned to get his way around the mother to get his demands met in a very different way. And I think this is something we have, at least I frequently advise the parents, that it's better that you unify as to how you're going to deal with the child, so as to have some development in the child in a uniform manner. On the same line, the behaviors and the responses to situations are so different between school and home that it's very necessary to analyze the child in all these different settings before we really decide as to what is the problem behavior, what is it that has caused the problem behavior, and what is the outcome. So I would look at it as a tri-dimensional approach to understand the behaviors in different settings and with different people and in different situations before we analyze as doctors for ourselves to advise the parents. So this is my one single take.
That is, you've said it so well. I think I just wanted to add one comment, that it is so true that kids respond so differently to different people within the family environment and across settings. And I think for me, when we do our assessment, we do touch upon all settings that the child is involved in. And one thing that I take away from these things is what the child engaging in, is it because of a skill deficit, or is it a behavioral issue, right? They'll say, he never does this with me, but then you go to school and you say he's able to do it. So then, you're looking at, oh, this is a motivational deficit, not a skill deficit. So really important to tease those things out. And the parent is sometimes shocked to see that he's able to eat his own food, for example, in the school, sitting at the table, whereas at home, the parent is having to feed him, or he refuses to eat, or he'll throw a tantrum to eat. He doesn't touch the spoon, whatever the case may be. That's just an example. But when we use video modeling sometimes from one setting to another setting, they're able to see and they're able to reinforce in the home setting and then build up the skills and generalize skills across settings. So yes, a cross-setting assessment, Dr. Veena, is what you mentioned, is really an important aspect of the assessment piece.
Yeah. Right.
Thank you. Please stay on. We'll have two cases, one from Turkey, one from India. So I think Turkey comes first. Start sharing the screen, please. I know we are going behind schedule, so we can be brief and to the point.
Yes, I will try.
Thanks, Seda. Thank you so much.
Good evening from Turkey to all participants and panelists. I would like to thank Dr. Kavita for her wonderful presentation and for your kind invitation. Today, I will present autistic spectrum disorder, two illustrative cases complicated with behavioral problems, diagnostic challenges, and treatment modalities. As we all know, autism spectrum disorder is a common, highly heritable, heterogeneous neurodevelopmental disorder that affects how individual interacts with others and the world throughout their lives. Approximately 2 to 3% of children are affected. Here in this chart, we can examine the heterogeneity of ASD. While core symptoms are common and shared in every patient, intellectual capacity, language development, and level of independence vary in each individual. Additionally, most cases are accompanied by psychiatric disorders such as anxiety, depression, OCD, and neurodevelopmental disorders like ADHD. Moreover, other medical conditions such as genetic, neurological like epilepsy, and gastrointestinal disorders are more commonly observed in these cases. And these disorders, of course, impact the quality of life. I will present two pediatric cases. One has ASD accompanying with neurologic conditions and genetic syndrome, also comorbid intellectual disability, ADHD, and anxiety disorder. The second one has ASD with psychiatric neurodevelopmental disorders such as ADHD, stuttering, Tourette disorder, anxiety disorder, and OCD. Psychopharmacological treatment, follow-up, and psychosocial interventions for ASD with behavioral problems will be discussed with recent guidelines. Our first case is a 9-year-old male presented with developmental delay, hypersensitivity to loud noises, and delayed speech when he was 20 months old. He also had older brother, which diagnosed with autism spectrum disorder. Our initial psychiatric examination showed that he had developmental delay, limited eye contact, joint attention deficits, decreased social interactions, tiptoe walking, sensory hypersensitivity, insistence on sameness, and flapping. His CAR score was 48.5. We consulted this patient to our neurology department, and consultation concluded with hypotonia. He had developmental delay in gross and fine motor skills. He had normal EEG results, and he had third ventricular enlargement on cranial MRI, but had no symptoms about this condition. Due to his coarse distinctive facial features, clumsy movements, and his brother having ASD, we consulted the patient to genetic department. Consultation concluded with Smith-Magenis syndrome. Although 75% of the cases are still clinically undefined, there are some genetic conditions that are known to be accompanied by ASD, like in our case, Smith-Magenis syndrome. During follow-up, his mother took him to a special educational center, and upon preschool when he was 4, he began exhibiting behavioral problems like headbanging, aggressive behavior toward peers, family, and teachers. And we decided to manage these problems with pharmacotherapy as recommended. Risperidone and aripiprazole treatment was initiated with the doses you can see in the slide. Concerning pharmacotherapy for treating aggression, our first choice is usually an antipsychotic like aripiprazole or risperidone. If those options seem to have failed, quetiapine, olanzapine, benzodiazepines, or the combination of an antipsychotic with a benzodiazepine may all be considered. And what about SSRIs? Overall, there is no meta-analytic evidence supporting SSRIs, but it may be reasonable to consider an SSRI when other non-pharmacological treatment options have failed. Like in our case, we initiated a SSRI, escitalopram, and for his anxiety, sadness, and behavioral problems, and patient benefited from this therapy. What about managing school and ADHD? Our patient had attention problems, hyperactivity, difficulty following instructions when he was 7. So we initiated methylphenidate and atomoxetine treatments, but methylphenidate caused irritability and harmful behaviors, and atomoxetine did not help to reduce symptoms. So we tried guanfacine treatment, and following this treatment, there was a decrease in attention deficit, hyperactivity, and behavioral problems. So our patient's current diagnosis is intellectual disability, autism spectrum disorder, ADHD, anxiety disorder, and Smith-Magenis syndrome. And his current treatment is guanfacine, escitalopram, and aripiprazole. Our second case is an 11-year-old male referred to us by his preschool teachers with complaints of stuttering, fixation on routines, object lining, tactile hypersensitivity, poor social communication with peers, limited eye contact, and motor stereotypic movements when he was 5 years old. Our developmental tests revealed a delay in fine motor skills, while other developmental milestones were age appropriate. We did some questionnaire about autism spectrum disorder to this patient, and he had high scores, and his CAR score was 32. His neurologic consultation was age appropriate. And during follow-up, we diagnosed this patient with autism spectrum disorder and speech fluency disorder and suggested special education with pharmacotherapy, but family was resistant. So at the age of 6, his complaints continued and even increased. Motor and vocal tics were added to the equation, and they even avoided psychiatric examination. At the age of 7, he reapplied, and we learned that during this gap year, his parents were divorced. His anxiety and other complaints like stuttering was severely increased. So we gave mother a medical leave to provide his care. At last, mother approved of pharmacotherapy and special education. After that, patient began special therapeutic education, and we began pharmacotherapy. For his anxiety and harmful behaviors, we started fluoxetine and aripiprazole, but there was no benefit from aripiprazole, so risperidone treatment was tried, and he benefited from it. For his ADHD symptoms, we initiated methylphenidate, atomoxetine, but he didn't benefit from this therapy, so we initiated guanfacine treatment. In this chart, you can see parental mental health issues predicted the maladaptive behaviors of these children, and negative life events like divorced parents in our case predicted the psychiatric diagnosis. And in this chart, you can see the comorbidities of our patient. Our patient's current diagnosis is autism spectrum disorder, stuttering, ADHD, OCD, anxiety disorder, and Tourette's disorder. His current treatment is fluoxetine, methylphenidate, risperidone, and guanfacine. I would like to talk about some treatment modalities. Early diagnosis and treatment play an important role in prognosis, like Dr. Kavita said. There is no proven treatment for all ASD cases. The most evidence-based treatment is educational behavioral methods. If there are no behavioral problems that could interfere with education, the patient is directed to education. The treating physician evaluates the effectiveness of the treatment at regular intervals. If there's a problematic behavior in a patient with autism, we recommend review the patient's history and level of functioning before and after the onset of problematic behavior, prioritize and qualify specific behaviors for treatment, consider all potential contributors like current medical problems, difficulties using functional communication, psychosocial stressor, maladaptive reinforcement patterns, and co-occurring psychiatric disorders. And after that, during treatment, use only pharmacological agents with sufficient evidence-based efficacy, use drugs at the minimum effective dosage, avoid drugs that may worse core symptoms or have negative cognitive effects, and monitoring is also important. Here, I put a chart for pharmacotherapy for children with autism spectrum disorder, maladaptive behaviors, and appropriate treatment options. And here, there are FDA-approved atypical antipsychotics. As a conclusion, the frequency of comorbid psychiatric disorders is very high in ASD, and if left untreated, negatively affects patients' functioning and development. Denial of diagnosis by parents, unfortunately, is not rare and affects the treatment course. Social and environmental support, along with psychopharmacological treatment and early initiation of the appropriate therapies, is crucial for these patients. Thank you for your attention.
Thank you, Dr. Seda. That was very crisp and nice presentation. So we will take the discussion and comment later.
Can ask Dr. Kavita to speak, because Kavita may not be there. Yeah, Kavita may not be there at the end of the second. Yeah.
Yes. So, Dr. Kavita madam, any opinion about this? Because both the cases were complex and they were controlled with medication. So what is your view about it?
I think, I mean, this is reflective of our earlier conversation, right? It's a reflective of our earlier conversation about, and I think, and one I do want to correct, I am not a doctor. I don't want to take credit when it's not due. So I just want to make sure I put that clarification. Dr. Seda, I think what you mentioned in the final chart where you talked about all these factors have to be looked at in terms of functional communication, adaptive behaviors. So in that chart, it's really evident that pharmacology is one aspect of the treatment protocol. And I think that's an important place to be, where we're not depending heavily only on medication. Particularly self-injurious behaviors and the kind of behaviors you noted in your presentations, they're quite significant. And as the kid gets older, these can become really very detrimental to their quality of life and health. So the behavioral management of some of these behaviors are important to go along with the pharmacological management. So I don't know whether you have the resources. I know every country has different systems set in place, and whether there's access to special education doesn't necessarily mean they're getting the right therapies, because sometimes special education could just be a separate school where the child is going and they're just managing the child rather than therapeutically intervening to teach skills and understand behaviors and teach them communication methods. So I think that those were my comments. I know it's a very complex case, but I do believe there's value in doing a functional assessment to have a behavior plan to go along with the pharmacological treatment.
Dr.
I'm so
Sejan
sorry.
was
I
the
have
mentor.
to leave right now. I have to drive.
Dr. Sejan is
I
the
am so
is the
sorry. I have to
mentor.
leave.
No, thank you so much. Thank you very much. Grateful to you.
Thank you. Thank you very
sparing your
much.
time.
Thank you very much.
Thanks. Dr.
Yes.
Sejan, you were the
All right.
mentor,
See you.
so
Bye
your
bye.
comments. Thank you. Bye.
Thank you.
Bye. Dr. Sejan, your comments.
We want to emphasize the importance of collaboration with special education, parental education, and parental support, and pharmacological management. Especially in the second patient, his parents also need evaluation, and they need to educate about the prognosis of the ASD and the effects of early diagnosis and interventions, but they avoid to start special education. During his follow-up, they divorced, and these negative life events affects the child. And also we know the multiple psychiatric comorbidity is very high in ASD, and we see this in this case. And we started pharmacotherapeutic medications, but they were limited. The effect of them is limited, and we gave his mother a report to support her child at school. We included school counseling to his treatment during entering the school, because his tics, vocal and motor tics, also very high. So this is a very challenging patient for us, following this patient. As you see, we added multiple pharmacotherapeutic medications to stabilize his situation. We want to emphasize here that the treatment should be collaborative with child, parent, and school. Counseling also is important. To support the family, to support the parent, to support the mother is very important in our case here. We should emphasize these issues here. And we use the medications as recommended in the literature in order. I can add this, maybe you could ask, or you could add some your valuable contributions to us.
Thank you so much. And I think for the experts, can we have the expert comments for both the cases, the second presentation also afterwards, so that to what want of time, so that you can just have comments for both of them and also final take-home messages. So Alpana, can you call the next presenter? And thank you, Seda, was a wonderful, amazing, quick presentation. And thank you so much, it's very interesting. Please.
Thank you, Dr. Seda. We'll now begin with the second case. So I'll ask for the screen sharing.
Pratik, please you ask your student. Pratik, please ask your student to share the screen. Yeah, Sutraj, yeah, Dr. Sutraj. Can you please be, I'm so sorry, can you please be brief as possible? I know it's not right, but we're running short of time actually. In any case, you were requested to have no, it's a 7 minutes presentation. So can you be as quick as possible? Yeah.
Yes, ma'am. Good evening, everyone.
Thank you.
I'm going to present a case of non-convulsive status epilepticus presenting as an acute onset autistic symptoms in a child with ADGR-G1 mutation under the guidance of Dr. Pradeep Kumar Panda, sir. So my case is a 2-year-old boy, Master V, who is a resident of Haridwar, who was under follow-up in our OPD. He presented at 9 months of age with complaints of epileptic spasms, which occurred in clusters, which was more on awakening and had around 20 to 30 episodes per day. He had a normal birth history, developmental history, and no significant family history. On examination, the child had a broad forehead with no obvious facial dysmorphism, no cranial nerve deficits. However, he had hypotonia of all 4 limbs and reflexes were present. So, since the child presented with epileptic spasms, we did an MRI for the child, which showed flattening of the gyre predominantly in the frontal region, suggestive of lissencephaly, with T2 sequences showing white matter hyperintensities. We also did an EEG for the child, which showed right frontal discharges. Then we did torch screening for the child and rule out torch infections, and CPK-NAC was also done, which was normal to rule out congenital muscular dystrophies. And then we went ahead with the clinical exome sequencing for the child, which showed homozygous missense mutation of exon 3 of ADGR-G1 gene with autosomal recessive inheritance, causing bilateral frontoparietal polymicrogyria and bilateral perisylvian polymicrogyria. The child was managed with corticosteroids and vigabatrin initially. However, the child had refractory seizures, so we started the child on valproate, topiramate, and levetiracetam. Following which, the child clinically improved, the spasm frequency decreased, and the child was gaining milestone. However, he again presented at 2 years of age with a minor febrile illness, following which he had acute onset stereotypical behavior, insomnia, mutism, restlessness, excessive biting, aggressive behavior, and motor milestone regression. So we considered the possibilities of autoimmune encephalitis for this child, since the points favoring autoimmune encephalitis were psychosis, sleep disturbances, and speech abnormality. However, the symptoms were of acute onset and the CS of autoimmune panel done was negative. Since the child presented with features of excessive irritability and stereotypies, we also considered the possibility of autistic regression. However, the child also had regression in the motor area, so an underlying CSWS was also considered. And since the child presented with autistic regression, we started the child on risperidone. However, there was clinical worsening following the intake of risperidone. So we did an EEG for this child, which showed continuous, abundant, generalized spike and wave discharges and intermittent polysex with disorganized background. So we considered the possibility of NCSC or ESES. However, we could not get an awake EEG for this child, as the child was having psychotic features and he was not cooperative. So we managed the child with injection lorazepam and oral clobazam, following which the child was having clinical improvement within 24 to 48 hours, which was suggestive of NCS. So just a few words about ADGR-G1 mutation. It is also called as GPR56 gene. It is adhesion G protein coupled receptor gene, and it encodes an orphan G protein coupled receptor, which is essential for the normal development of the cerebral cortex and the cerebellar morphology. And loss of function of this ADGR1 gene causes disrupt the normal migration of the neurons in the developing brain. And children with ADGR1 mutation usually present with features of motor and cognitive impairment, strabismus, nystagmus, and seizures. And it is usually related to bilateral frontoparietal polymicrogyria and perisylvian polymicrogyria. However, there has been multiple case report associating ADGR1 mutation to lissencephaly, like that of our index case. So just my take-home message is that in a child presenting with acute onset autistic regression, an EEG should always be done to rule out NCSC and ESES.
Thank you so much, Dr. Pratik. Would you like to have comments and some message?
I just wanted to highlight a fact. We initially thought of it was a CSWS and the child will require a lot of corticosteroid and it will not improve. I wanted to highlight that the child became completely normal after giving lorazepam and clobazam, and the child had worsening after risperidone. So sometimes we also need to consider this NCSC, especially in this cases with lissencephaly and other things.
Dr. Girimaji, I have one question for you. Like among all the problematic behaviors, stereotype is as well as self-mutilation. So how do you tackle these two problematic behavior in autistic children?
Stereotypies are part and parcel of autism. You can't remove it. I mean, you simply can't give any medication. However, if the stereotypies are very problematic, child keeps on jumping, running here, running there, running there, running there, turning, whirling, and to the exclusion of all other activities. Moment the child gets a little bit of free time, child gets into this. This kind of an excessive stereotypy, which is there in all settings, which is affecting the child's learning and development, then it is a fit case for giving medication. I usually try, nowadays I don't try risperidone, I try aripiprazole. I try with just 1 milligram aripiprazole, keep on building it up and see whether it works. So I think quite often it works. If it does not, then you can try risperidone. These are the only two drugs that one can try. No other, many a time this stereotype is mistaken for hyperactivity and ADHD. These children, sometimes they are in the same spot. They are not running around. They are not shifting their activity from one to another. That's how you can distinguish ADHD from stereotype. So the point I'm trying to make is, if it is, part and parcel of ADHD, you can't. The only way you can bring it down is a positive engagement, positive interaction, teaching skills, and getting the child, structured activity and activity structure, time structuring, activity scheduling, and things like that. That is that tendency. But certain amount of stereotypy in those who have is likely to remain. So it's better to leave it. Let the child have a little bit of stereotypy. It's fine. SIB. SIB also can be part of stereotypies sometimes, or it could be part of the problem behaviors which Kavita told you about. It can be, an outcome of a number of antecedents and predisposing factors. And if that is the case, then it's worthwhile doing a very detailed functional analysis and try. Very often, see, in SIB, consequence management doesn't work. You have to do antecedent management. You have to stop the behavior before it occurs. So what are the settings and what are the determinants, what are the triggers that bring about this behavior? And then try to manage those things very often works. If it does not work, then you will have to do a much more detailed analysis to see what's. I'll give you an example. I saw one child, all right, moderate degree of ASD, 8-year-old boy, all right, going to school and all. 2-month history of having become irritable, sleepless, severe SID. What had happened was he had developed depression because of number of multiple stressors in the school as well as at home. So it was very clear that his mood had gone down, and what you're seeing as SIB was part of depression. So he was given fluoxetine. I gave him fluoxetine actually, and he did resolve. And many, not just fluoxetine, I looked into all the stressors and then minimized the stressors in the school, in the home, and thereby we worked as a team. Thereby the problems came. It takes time, but it came back. So very detailed, meticulous evaluation of the problem, not just diagnostically, but from a functional behavioral perspective, actually opens avenues for management.
Okay, thank you, sir.
Sir, your opinion on both the presenters' cases, please. And then we'll and your take-home message, and then we'll go to each of the experts for their comments on the cases and their take-home messages.
I think for the first two cases from Turkey are really, very severe ones, where multiple comorbidities were there, and a number of family issues, and Smith-Magenis syndrome is known to have so many. It's called as a behavioral phenotype. So many kinds of behavioral disturbances, very well known. They have hugging behavior. They have behaviors of putting everything in their mouth and everywhere, all the orifices. They have self-injurious behavior. They have tics. They have ADHD. Number of problems. So it's not surprising for me that this child needed so many medications. There are some. These are exceptional cases. These are not regular cases. And the second one also had multiple problems. And probably, like Kavita said, more vigorous functional behavioral perspective could add to the effect of medication. That's about the first two cases. The last case, I am reminded of one child, a 12-year-old boy who presented with mutism of about 30 days duration or so. He was seen initially in neurology. They said mutism. They sent it back to me. I saw that there was some problem. I mean, it was not simply mutism. I thought. Then I scratched my head, and then I said, okay, we'll get the EEG done. It turned out to be ES, and then it was treated, and then this boy, made remarkable but gradual recovery. So there are very many organic presentations which can present with autistic kind of regression. One of the notorious things, of course, is autoimmune encephalitis, and in very young children, in 2, 3, 4-year-old children, and of course, very severe experiential deprivation. We have seen so many, and I'm sure you all have seen, what has come to be known as virtual autism following pandemic, where that's, children already vulnerable, having some deficits, going through severe environmental deprivation, no stimulation, nothing, nobody sitting, playing, talking, interacting, teaching with children, and the screen being there in the child's hand. Child loses all the skills and develops autistic kind of picture within no time, within 3 months. So such children, if you detect early and provide early intervention, stimulation, interaction, and then you can get them out of it.
Thank you,
So
sir.
your take-home message, take your message,
Yeah,
because we will not come back.
Yeah, problem behaviors, very often part and parcel of the ASD. Do not kind of, dismiss it as part of ASD. Only look at it as that's what is called as diagnostic overshadowing. Diagnostic overshadowing is a clinician error in which clinician misattributes the symptoms of a comorbid disorder to autism. So you take it as a separate, try to see, analyze, see whether it is really part of autism or it's part of separate problem behavior or a comorbid psychiatric disorder. Take necessary steps to manage.
Thank you, sir. Dr. Satyabama, your view on both the cases as well as the take-home message, please.
Okay, actually, echoing what Dr. Girimaji has said, I think the first two cases were very complicated. And usually, if we do see it back home here, we'll be co-managing with the child psychiatrist. And the only thing I would like to add is a bit of the behavior analysis. But I suppose in very complicated cases, and it's going to take a bit of time to look into that. They need to do the medication bit first. On the second case, I think in any child with an acute autistic sort of a presentation, I think we need to rule out the organic component first. And I think all of these children would warrant investigation, at least EEG or MRI, and with also involvement with our pediatric neurology colleagues. Just one more thing I'd like to add just now, the question you asked Professor Girimaji and about repetitive behavior, stereotypies or repetitive motor behaviors. One of the things we tend to do in our clinic is that we do this behavioral assessment, and very often parents will tell us that they have this repetitive behavior when the child is bored, when they're not engaged. You see, because our clinic sessions take a long time and the parents know why they're there, the kids have got no idea why they're there. So, you can see this self-stimulating behaviors. So one of the things we look at is also to look at the child's functioning level, the cognitive level, and what the child likes. So sometimes, if the cognitive level is very low and the child sort of is only at the level of exploratory play, sometimes we suggest like whether they can use any sensory toys with the help of our occupational therapist. Just keep the hands busy a bit, so when the parents are doing something, there's an alternative activities. Even though there's plenty of toys in our child development clinic, we all know that children with autism, they may not go and just help themselves like typical children do, right? So this is us planning ahead, and we tell the parents ahead that, why don't you just bring some of these? The sessions are going to take some time, so keep them occupied with something so you don't see this kind of behaviors. And we also try and convert their interest to something a bit more sort of socially acceptable. So, like something that's more acceptable as a toy or as an activity rather than doing something that's related to their obsession. So my take-home message is challenging behavior is common. It requires a comprehensive evaluation, and in that comprehensive evaluation, what will work is if you find the diagnosis, if you find the functioning level in terms of the language, the cognition, the adaptive function, and also the comorbidities and the background of the family, because there may be family problems as well, socio-economical issues as well. So in all this will help us figure out, one of the better ways to help them to manage the behavior, and also to consider medication, as they work hand in hand in some cases who need both of this. Thank you very much.
Yeah, thank you very much. I think Dr. Veena madam has left.
Okay, Dr. Sefkan. Dr. Faisal.
Dr. Faisal also is not there.
Okay, Dr. Sejan, you want to say something? And Dr. Kalra will ask, and then we'll.
I agree with two of our experts, Grimashi and Tata Yabama. I agree with you. Problem behaviors arise from multiple reasons. We should evaluate comprehensively, as you said, and the treatment plan is also should be comprehensive. Psychiatric comorbidities is high, and we shouldn't miss the treatable diagnosis, pharmacotherapy, and educational, behavioral educational, and parental educational for child and for parents and for schools, maybe in our country like this, is very important. I want to add this.
Thank you. Alpana, you want to give you some message from your side?
Before that, ma'am, there is one question on the question answer box. We'll take that. So any role, it has been asked that whether there is any role of drugs like suramine or
We have already discussed last time, there's no point. We have already talked about this medication last time. So I think we just, and it was not relevant to this. It has been talked about and it's there. We've already told about it. And initially it has been, first we had AST mimics. Right now, there are no proven rules in any case right now. For transcranial magnetic stimulation, we have completed a study in which we have shown, we have developed a theta burst protocol, and it's actually mentioned in one of the sessions previously. And this suramine has no, they're all being studied and all, and there's been introduced in India also, it's getting introduced, but right now they're not a proven rule. Dr. Satish, you want to add something about it? You can add and then we can add.
Recently,
Okay.
Coming up, they run their course. So
yeah,
I think
that's
one of them have really stood the test of time and they know evidence.
We're just waiting and watching if something comes, obviously, but then only thing is request that parents should not go and try up, and we should not be prescribing something till we have evidence based, because it's a chronic lifelong problem.
Especially expensive ones. I mean,
Sir, but even if it's not expensive, I feel there is something as the benefit, then only we should do, otherwise not, right? Yeah. Okay. Alpana, you want to say something from your side? Then Mahesh, want to say something? Yeah.
Yeah. So I will like to say that the treating physician must identify the exact risk factor behind this problematic behavior. And as Ms. Kavita said very clearly, that whether it is physiological, biological, or it is learned, that we have to see. And very, very important point, that whether it is a comorbidity of any other underlying disease. And once we identify this, it becomes very easy to manage. I think the comprehensive care is very important. It is not only drugs or only therapy. It is the combination of both. So, and lots of patience and participation from the parents' side is also very, very important to manage this problematic behavior in different cross settings. Thank you.
Thank you. Mahesh?
Yes, ma'am. It was really nice talk by Dr. Kamal. As we discussed, very good communication between the neurologist or psychiatrist and the psychologist is really important here. And the parents of a person has to be taken care of. Only medications may not really help.
Yeah. Yeah, thank you. Actually, the idea of keeping this session was because what we see in our, practice, that you keep getting, the parents will go to multiple people, pediatric neurologists, psychiatrists and all, and they will be host of medications being given, and which are, so we have to understand how we should look at the behavior. And I think pediatricians and psychiatrists are not that trained to look from that point of view. I mean, so I thought that was maybe a psychiatrist may be a bit trained because of their psychiatry otherwise, but I thought that was very important, and holistic management is important. And we have analyzed 1872 of our children of autism. 80% had comorbidities, out of which 57% had ADHD. So, and multiple comorbidities also present. So that is why we have to look for comorbidities and go on. But trying to have a look, and because that parent child dyads, what she had shown with the parent centric and the child centric, and how by the reaction we are creating, we are actually reinforcing the behaviors, and that is something important. And why the punishment is dissuaded, because you are telling no, but you are not telling what not to do, but what to do you're not telling. So child is still lost. And in India, if you have which are very less now because of nuclear families, when you have joint families, then the grandparents, the behavior between parents and grandparents are more protective. That adds to the complication. Thank you so much for all of you for joining from across the globe, and for all of you for staying so long. And we finished this autism SIG this month. We will come back after 9 months in January again for the autism SIG, which will be the last SIG of the current tenure. And we come next week on with the neuromuscle SIG second round again. Thank you so much. See you next week. And we will not be having in the second week of May because of ICNC in Cape Town. So we will be having on 1st, but we will not be having on 8th. And then we come back on 15th. Yeah. Thank you so much.
Thank
Bye.
you very much. Thank you, everybody.
Thank you, everyone.